El Colegio Mexicano de Ortopedia, en su 75 aniversario, presenta su segundo Congreso Virtual 2021. El doctor Eric R. Wagner cuenta con maestría y doctorado en medicina. Realizó su residencia en cirugía ortopédica en la Clínica Mayo en Rochester, Minnesota. Fue becado en Harvard's International Shoulder and Elbow Fellowship en Massachusetts General, bajo la dirección de John J. P. Wagner, y en los hospitales Brigham and Women, bajo la dirección de Lawrence D. Higgins, en Boston, Massachusetts. Como parte del componente internacional de la beca de Harvard, el Dr. Wagner se formó con líderes mundiales en artroplastia y artroscopía de hombro, incluido Pascal Boilao en Niza, Francia, y Laurent Lafosse en Annecy, Francia. El Dr. Wagner actualmente trabaja en el Departamento de Cirugía Ortopédica de Emory Clinic, donde se especializa en pacientes con patologías complejas de hombro y las extremidades superiores, que incluye patologías complejas del manguito rotador, artroplastia de hombro primaria y de revisión, inestabilidad recurrente del hombro, por ejemplo, síndrome de Ehlers-Danlos o hiperlaxitud, patologías escapulares y hombro paralítico. Ha publicado más de 210 artículos en revistas arbitradas y realizado más de 380 presentaciones en eventos nacionales e internacionales. Es autor de más de 10 capítulos de libros. Es miembro del consejo editorial del Journal of Hand Surgery, Techniques in Hand and Upper Extremity Surgery, European Journal of Orthopedic and Traumatology, y participa en varios comités en la Sociedad Estadounidense de Cirugía de la Mano y la Sociedad Estadounidense de Hombro y Codo. El Dr. Wagner hablará sobre maximización de la función, estabilidad en artroplastia inversa de hombro, el papel de las transferencias de tendones.
For the opportunity to talk about maximizing function and stability in the reverse using tendon transfers. My name is Eric Wagner, and I'm at Emory University. My disclosures can be found at the AOS website, but none are relevant to this presentation. However, I should disclose that I am a product of my mentors, both here in the United States as well as abroad. We have come a long way since the reverse shoulder arthroplasty was first introduced to us by Paul Grammont back almost 30 years ago. Whether the total shoulder arthroplasty increasing at an exponential rate higher than hip or knee arthroplasty in the United States, in particularly secondary to the advent and the increasing rate of the reverse shoulder arthroplasty, and in part due to these great longitudinal long-term studies showing very promising outcomes in patients, including this one by Christian Gerber. However, the reverse shoulder arthroplasty still has limitations, and patients still are not completely satisfied given these functional limitations. As Constant and Merle taught us, patients want to get their arms above their head, they want to externally rotate, and they want to get their arms behind their back. And thus, as of today, the reverse shoulder arthroplasty, a non-anatomic shoulder, is not equivalent to an anatomic shoulder arthroplasty. Whether you're talking about limitations in patient-reported outcome measures like reaching a high shelf or washing their back or fastening their bra, returning to different sports that they want to get back to, and comparing themselves to the anatomic shoulder arthroplasty with regard to their ultimate return to sport rate. And this is in large part due to the limitations in internal rotation. As Joe Walsh taught us, this worsens over long-term follow-up instead of getting better, leading to difficulties in activities of daily living, such as toileting. In head-to-head comparisons over and over again, the anatomic shoulder arthroplasties outperform the reverse shoulder arthroplasties, in part from soft tissue limitations and in part from different bony and implant impingement. And there's many ways to optimize reverse, and that's not really the point of this talk, but I do want to kind of talk about some of them. On the glenoid standpoint, lateralization, larger glenospheres, inferior placement, neutral version, all of these have improved our outcomes for the most part, and potentially improved our need to do tendon transfers quite as often. The larger glenosphere kind of makes sense. So the larger the glenosphere, the less or the longer you're going to go around the sphere before you actually impinge. Inferior placement also kind of makes sense because you're not going to impinge when you're extending or reaching behind your back. Correcting glenoid retroversion also makes sense. When you look at your don't correct glenoid retroversion compared to when you do, you're going to impinge much earlier along that circle if you don't correct it than if you do. And same idea with superior inclination. Once again, if you don't correct it compared to if you do correct it, you're going to impinge much earlier if you don't correct it than if you do correct it. And then finally, you have to consider soft tissue restraint when you're talking about all of these implant techniques, whether you're talking about inferiorization, whether you're talking about lateralization, or whether you're talking about correcting inclination with a larger glenosphere, you're going to have some soft tissue constraints. And these are all things to consider when performing this procedure. But I'm also here to talk to you about another consideration, and this is the tendon transfers. So in patients that are markedly limited, meaning their actual muscle available to use is very limited, as you can see in this example of true pseudoparalysis, very little ability to externally rotate or elevate. These type of patients, as Joe Walsh has talked to us about it, Pascal Boulot has talked to us about, these type of patients had very little posterior superior rotator cuff remaining. And thus, they have very little musculature to drive even after the reverse is done. So as you can see in this example, these patients who have very little posterior superior rotator cuff and therefore very little external rotation power or ability to position their arm in space are not the same as those patients who have a hypertrophic teres minor and thus can sort of make up for the fact that they have this irreparable infrasonatus. When you lose these external rotation forces, you need something to restore them, to enable patients to better position their arms in space. And this is the role of the tendon transfers. And in general, you want to pick a muscle that has a similar line of pull, similar excursion and tension, replace one function with it, so external rotation, and have an M4 or better strength. And when you're considering this for cuff pathology, you're thinking about either the latissimus dorsi or the lower trapezius. And while I prefer the lower trapezius for native shoulders that have massive irreparable posterior superior rotator cuff tears, for the reverse shoulder arthroplasty, the latissimus dorsi is equivalent to the lower trapezius, given that the joint is a semi-constrained joint. And thus, the lay episcopal transfer is really the mainstay. And this is described by Pascal Boulot and multiple other European colleagues of mine who have shown that basically rerouting the latissimus by itself or latissimus with the teres major can create a very powerful external rotator and can correct some of these external rotation deficiencies that people have. JP Warner's also helped us to understand the biomechanics behind this and its ultimate indications. And just like many of these other papers have kind of reinforced the promising outcomes, including many that we published ourselves, in general, those patients who do not have active external rotation, as Mark Frankel talked about in this study, do quite well with the lay episcopal plantar. You can see this patient 6 weeks post-op, she had no external rotation, a 50-degree lag sign. You can see 6 weeks post-op, she's already regained external rotation. The latissimus dorsi, when you're harvesting it, can be found just superior or just superficial to the teres major. It's along the bicipital groove, and you can kind of see here. So the radial nerve going over the top, the actually already going superior to it. And here's your latissimus dorsi, just inferior to the subscapularis and just superficial to the teres major. Thank you, Boston Elson, for this wonderful video that I helped him to make. You can see latissimus being inserting just medial to that bicipital groove here. You can also see it just under the lesser tuberosity where the subscap inserts. And so there's some other transfers I want you to at least know about and consider when you're talking about shoulder arthroplasty. And this will also help you to better understand at least how to harvest latissimus in the lay episcopal transfer. So this 42-year-old who has a failed subscap after hemiarthroplasty. And you can see here, this is a pretty difficult problem for this 52-year-old. She's young, she's active, and she's very limited with her limitations in range of motion. The good thing is she's not anteriorly dislocated. So the question is, what do we do for this patient? Do you leave them, even though she has pain and limitations in her function? Do you revise her to a reverse, which is probably the most reliable ultimate surgery, but she is 42 and very active? Or do you perform an anatomic shoulder arthroplasty and add in a latissimus dorsi transfer as well as an anterior capsular reconstruction to help augment that anterior superior rotator cuff tear? So this is me. I'm tagging the remnant of the subscapularis. Not a lot of good tissue left, but some of the inferior subscapulars might have been okay. Then I'm exposing the latissimus, and you can see the homins on each side of the latissimus. I'm tagging the latissimus before I actually remove it from the humerus. And then now I'm using a knife to sharply dissect it off its insertion on the medial aspect of the bicipital groove. I'm also sharply dissecting off of any adhesions to the teres major deep to it. And I like to use a knife for most of this dissection, but then as you go deeper, it's nice to switch to scissors and kind of get those deep adhesions with the scissors. So you can see we've released the latissimus for the most part and are crack-awing up and down to prepare for the transfer. And then after performing a crack eye, then we'll perform the revision arthroplasty. So taking off the humeral head, using osteotomes to take out the stem. And then I like to use a metal cutting burr before I impact this humerus out and remove it with a pencil tip impactor. Then I prepare the glenoid, cement the glenoid, and place the glenoid implant before, and then afterwards I'll place the 3 anchors to anchor in that dermal allograft for the anterior capsular reconstruction. I then use this burr to prepare the lesser tuberosity, and then placing multiple interosseous sutures, including the sutures to the latissimus dorsi. I'll place those transosseously, place the stem, and then I first anchor the latissimus dorsi. As you can see here, I'm tying in the inversa venatus at the superior aspect of that lesser tuberosity. I'm then placing these stitches into the anterior capsular reconstruction, as you can see here. And then placing those same stitches through the remnant subscapularis that you can see there. Then we're ultimately tying them in place, and you can see our ultimate outcome with the tendon transfer, the anterior capsular reconstruction, and the subscapularis coming over the top. I then place a couple interval stitches to help with that anterior superior escape. Here's another consideration. So a patient has an unstable endoprosthesis that previously resected for tumor. So what do you do with this patient? Maybe leave them, revise it to an endoprosthesis. Well, we chose to do an APC plus tendon transfers. So you can see this allograft prosthetic composite with the locking compression plate, drilling some holes in the allograft for a deltoid insertion, doing a latissimus to inversa venatus insertion and pectoralis to subscap insertion transfers, and then bring the deltoid over the top. Ultimately, you can see our final construct, and this patient did quite well, at least up till 12 months, as you can see in this image on the right. So my final thoughts, when you are trying to optimize a reversal or arthroplasty, you should think about certain considerations on the glenoid side and the humerus side with regards to technical considerations. But you also should consider augmenting soft tissue, particularly when patients don't have active external rotation or dynamic stability of their shoulder. Consider some of these muscle transfers. I'd like to thank you for your time, and please reach out to me if you have any questions or would like to participate in any multi-center trials.